I want to talk about migraine prevention in terms of experience from the United States and implications for the global pandemic. And in order to talk about this, I want to give you some background. The problems that we have are that patients' unmet need in migraine treatment are amplified during the time of restricted movement during the pandemics. And the question is whether the new therapeutic advances might allow us to help our patients when access to practitioners is difficult. And I can't leave without pointing out that the new medicines are superior to our older medicines when evaluated appropriately, considering both adverse events and therapeutic benefit, and also considering placebo. I want to, first of all, talk about which groups of patients we might be treating and how we define them. We know that episodic migraine can progress to chronic migraine and to medication overuse headache. And we know from a very large population-based study, the American Migraine Prevalence and Prevention Study from the last decade, that the average annual incidence of conversion from episodic to chronic migraine is 2.5%. We also know that patients can move from chronic migraine back to episodic migraine, that is, go below 15 days of headache per month. And our goal in migraine treatment is to prevent patients from transforming from episodic migraine to chronic migraine and medication overuse headache, and also, if they are already in chronic migraine or medication overuse headache or both, to move them back to episodic migraine. But what we have learned in the last 3 years through another large population-based study called the Cameo study is that it turns out that the artificial line of 15 days per month that we've been using to define chronic migraine is probably not correct. And patients with high-frequency episodic migraine, when evaluated with month-long diaries done every 3 months in the Cameo study, turned out that they were going back and forth between episodic migraine and chronic migraine. Well, at month 1, they might have 13 headache days per month and be considered high-frequency episodic, and then at 3 months later, they might have 18 headache days per month and be considered chronic migraine and go back and forth in what was referred to as the roller coaster of episodic and chronic migraine. It suggests that 15-day line is probably not accurate for describing what is going on with episodic and chronic migraine. As a result of that, Chalmer and a group published in September Encephalalgia new proposed criteria for chronic migraine. And what they recommended was that for at least 3 months, migraine headache day frequency would be 8 or more days per month. You wouldn't require the patient to be at 15 headache days per month. You would require them to have migraine at least 8 days per month. And that would take all of the patients who currently are characterized as having high-frequency episodic migraine and make them all chronic migraine. They're all equally disabled and they're moving back and forth across time anyway. If you take these patients who have chronic migraine and you give them conventional oral migraine preventive medications, antidepressants, anti-epilepsy drugs, beta blockers, and so forth, there was a remarkable U.S. claims database analysis that was published in 2015 of 8,688 patients evaluated from day 1 across a year who had chronic migraine. 83% of them who initiated a trial of oral migraine preventive medicines were no longer taking that preventive treatment a year later. And the reason that they were not taking the drugs was evaluated in a study called the International Burden of Migraine Study 2. And not surprisingly, and this was in 1,165 migraine patients, not surprisingly, the two reasons they stopped the drugs were lack of efficacy and side effects. So if you're a provider and you're giving a medicine to somebody and you know that 83% of the time they're going to be off that in a year, that is therapeutic futility epitomized. And we've got to do better than that. And that is why the evaluation of the new treatments is so important. There are 4 monoclonal antibodies available in the United States. Aranumab was the first one approved in May of 2018, and it's the only monoclonal antibody that targets the CGRP receptor, and it's administered monthly at home by patients. Eptinezumab came next. It was approved in the U.S. in September of 2018, and it targets the CGRP ligand and is administered either subcutaneous monthly or quarterly. Galkanazimab was third, also approved in September of 2018. It also targets the CGRP ligand, and it's administered subcutaneous monthly at home. Galkanazimab was the first medicine ever approved by the FDA for prevention of episodic cluster headache, not migraine. And it was approved in June of 2019 for that at a different dose, also administered monthly at home for the duration of a cluster headache cycle, an episodic cluster headache cycle. The last monoclonal antibody approved in the United States was Eptinezumab, approved in February of 2020. It targets the CGRP ligand. It is the only one that's administered intravenously, and it's administered quarterly. Those are the 4 that we have, although most of our experience, not surprisingly, are with the first 3. These drugs work in very dramatically different ways from the oral drugs which preceded them. One way that they show a dramatic difference is in the early onset of their effect. They have unprecedented fast onset in the pivotal trials. For example, and so all of them, all 4 of them, separate from placebo in less than a week for both episodic and chronic migraine prevention in the pivotal trials. And one can see drops in mean monthly migraine days evident within a week for Aranumab, Eptinezumab, Galkanazimab, Eptinezumab, and Eptinezumab actually in the study that evaluated patients with a lack of success with 2 to 4 previous preventive medications in a placebo-controlled trial showed the likelihood of migraine dropping by day 2. And in addition, Eptinezumab showed improvement in not just migraine pain, but migraine-associated symptoms of nausea and photophobia and phonophobia in less than a week in the pivotal trials. Eptinezumab, the intravenous one, was had as an outcome measure what was the likelihood of a migraine in a day prior to the administration of the intravenous treatment on any given day in the baseline of a month, and then what was the likelihood of a migraine for a given patient within 1 day, within 24 hours of infusion. And remarkably, for both episodic and chronic migraine, there was greater than a 50% drop in the likelihood of a migraine within 1 day of the intravenous infusion of Eptinezumab. These are very, very fast onset therapeutic outcomes. The next thing we're interested in is how well they maintain their effectiveness across time. We have 3-year data on Galkanazimab and Eptinezumab. We have 5-year data on Aranumab, and the drop of mean monthly migraine days is seen dramatically at the end of the randomized controlled trials for these drugs. And for the looking at 4.5 years for Aranumab, there continues to be a drop in mean monthly migraine days for the episodic migraine patients. So they start with an average of 6.2 days per month of mean monthly migraine days, and by the end of 4.5 years, they've dropped by 4.6 mean monthly migraine days, and that suggests no loss of effectiveness. They work in the target patient population. The European regulatory authorities recommended that the companies evaluate these drugs in patients who have had a lack of success with at least 2 to 4 previous preventive therapies. Aranumab was studied at the 140 milligram dose in episodic migraine across a 3-month trial. Eptinezumab and Galkanazimab were studied for both episodic and chronic migraine across 3 months, with Eptinezumab studied in monthly and quarterly, and Galkanazimab with a loading dose and then monthly. And all of them showed benefit in the patients who had a lack of success with at least 2 to 4 previous preventive therapies, with a magnitude of benefit that was similar to those who did not have that previous prophylaxis failure. So in our target patients, these drugs work very well. And from a standpoint of what we wanted to do at the beginning, that is to move people from chronic migraine to episodic migraine, and from acute medication overuse to non-medication overuse, all of them show benefit in that regard. All of them show that a majority of patients convert from chronic migraine to episodic migraine, and from medication overuse to non-medication overuse. And in the case of Aranumab, this occurred in patients who were overusing simple analgesics and triptans and combination therapies. And that actually differentiates a little bit from botulinum toxin A, where in the regulatory trials, botulinum decreased triptan use, but not analgesic and combination analgesic use. But this is a very important finding, that these medications appear to move patients from chronic to episodic and from overuse to non-overuse. And this was in patients who, this was with Aranumab, and data were presented at the American Academy of Neurology last year for Eptinezumab for this as well. The other really important aspect of these is that these medicines reduce healthcare resource utilization. And a study was published in 2018 that looked at Galkanazimab in terms of healthcare provider visits, emergency room visits, and hospital admissions. Galkanazimab reduced the healthcare resource utilization in terms of healthcare providers, emergency room visits, and hospital admissions very dramatically, comparing baseline across the treatment period. And this would suggest that the drop in healthcare resource utilization probably is so significant that doing the step edits that are currently recommended by regulatory authorities and payers may be penny wise and pound foolish. I'd like to say a few words about other ways of showing superiority for the new treatments compared to the older treatments. One way to evaluate this is placebo-subtracted evidence of effect. Therapeutic gain is defined as the active response minus the placebo response, and the higher the better. You can take the reciprocal of the therapeutic gain, and that is referred to as number needed to treat, or NNT. For NNT, the lower the value, the better. So you don't want to have to treat a lot of patients to get a benefit compared to placebo. Therapeutic harm are the active adverse events minus the placebo adverse events, and NNH is the reciprocal of therapeutic harm, for number needed to harm. For NNH, the higher the value, the better. The NNH to NNT ratio is the likelihood of being helped or harmed, LLH. And again, the higher the value, the better. You don't want to have to treat, you don't want to have a side effect with a very low number of patients. You want to have a lot of patients before you get a side effect. But on the other hand, you don't want to have to treat a lot of patients before you see a therapeutic benefit. The NNH to NNT ratio describes the value of an intervention as a risk-benefit, as a risk-benefit analysis number. That is, number needed to harm, you want high. Number needed to treat, you want low. And a study by Pamela Vo that was published in Cephalalgia in 2019 looked at the NNH to NNT ratios for Aranumab at 70 and 140 milligram, topiramate, onabotulinum toxin A for chronic migraine, and for the 2 doses of Aranumab and topiramate and propranolol 160 milligrams for episodic migraine. And remember, the higher the number for NNH to NNT, the better. So the numbers of NNH to NNT for topiramate, propranolol, and botulinum toxin A were 2 to 4. The NNH to NNT ratios for Aranumab were 42 to 167. Orders of magnitude difference. If you're going to do a placebo-subtracted analysis, you have to take into account the adverse events as well as the efficacy. These numbers really suggest that the monoclonal antibodies are a paradigm shift with a significant improvement over previous treatments. So how has this changed my practice? Well, first of all, we have in the United States an American Headache Society position statement published in the journal Headache in 2019, which was worked out with payers and regulatory authorities and patients, as well as professional healthcare providers. And what this position statement says is that the new treatments should be available to be prescribed by any licensed healthcare provider to patients who have low-frequency episodic migraine, a lack of success with 2 previous preventive agents, and documented at least moderate disability or impact. They should be eligible, so patients should be eligible if they have high-frequency episodic migraine, meaning 8 to 14 headache days a month, if they've had a lack of success with 2 previous preventive agents. You don't need to document disability. If they have high-frequency episodic migraine, they're clearly impacted. If they have chronic migraine, either a lack of success with 2 previous preventive agents or a lack of success with botulinum toxin A. And again, no need to document disability. Most payers, most regulatory authorities in the U.S. are using this position statement, which is available without copyright for download, as the basis for who should be receiving the new preventive treatments. And because they're not differentiating between episodic and chronic migraine, I don't have to differentiate it for consideration of a preventable monoclonal antibody, unlike for botulinum toxin A, where the patient has to have at least 15 headache days per month. I can try a monoclonal antibody for patients with frequent disabling migraine after 2 preventive categories have failed. And as I pointed out, because the majority of patients convert from acute medication overuse to non-overuse, I don't have to prescribe an acute medication wean for the majority of the patients. Instead, I just prescribe the monoclonal antibody and watch the acute medications drop. We have over 2,000 patients on monoclonal antibodies at Dartmouth in New Hampshire. We offer the monoclonal antibodies after 2 preventive categories have failed, and if they have significant disability or impact. Many have disabling episodic migraine. Many have high-frequency episodic migraine that would meet the new proposed criteria for chronic migraine by Chalmers. And the 2019 AHS position paper eased access and allows the most disabled migraine patients for whom preventive medicines have failed to be treated with monoclonal antibodies. During the pandemic, the majority of our patients are being managed remotely with telemedicine, and many patients previously using botulinum toxin A or repeated nerve blocks are requesting a switch to monoclonal antibodies so they don't have to come into the clinic and take a risk of exposure. And what I've learned is that we've been able to start patients on monoclonal antibodies and follow them entirely by telemedicine remote visits. These specific, effective, and tolerable therapies have dramatically optimized the likelihood of success for the patients. The convenience with infrequent delivery, long and cumulative duration of effect, and high tolerability have improved patient adherence and enthusiasm. We just have the pharmacies mail the monoclonal antibodies to the patients. And the home self-administration has been useful during the pandemic because it's reduced the need for clinic visits during a dangerous time. I might add, I've never heard before such dramatic stories of lives restored as those I'm hearing about with the monoclonal antibodies. I think it's worth concluding with a quote from Dr. David Dodick, who's president of the American Migraine Foundation. And David said, "I see a day within our careers when it will not be acceptable to treat patients by having them cycle through a ragtag group of drugs that over 80% of patients will stop within a year just to get to disease-specific and migraine-based treatments that were specifically designed to treat the disease." And I really agree with that. I think we need to get away from the step edits and get these drugs to the patients who are disabled and need them.